Our next speaker is Solveig Hart. And Solveig has been working as a physical therapist for 27 years, 19 of those at Seattle Children's Hospital, and including children followed in the Neurodevelopmental Clinic. Solveig recently relocated with family to Camas, Washington, and is now working part-time at Columbia Pediatric Therapy, focusing on infants and young children with developmental concerns and torticollis. I will now turn it over to you, Solveig.
It really is an honor and pleasure to be here presenting at the Duncan this year. It's my favorite seminar of the year. I want to say hello to all my Seattle Children's Hospital colleagues and former Seattle colleagues. I miss you all. It's good to be back virtually. Also want to say congratulations to Dr. Bry for being awarded the Duncan Award. It's been really an honor working with you over the years. Also want to acknowledge Dr. Amy Chambliss, who graciously contributed some slides regarding neurodevelopmental clinic and rehab medicine roles in the management of children with spina bifida. And then a huge thank you to Connie Lebo, who helped me, just invaluable help with my literature review. So today, I am very excited to present a brief overview of the roles of neurodevelopmental clinic, rehab medicine, and physical therapy in the care of and management of children and families with spina bifida. And then I'm going to spend some time describing a new functional classification system for these individuals. And finally, I'm going to present some relatively recent literature describing adjunctive therapies for this population. And I have no conflicts of interest to disclose. Looking at the roles of the neurodevelopmental clinic, it's very multidisciplinary approach for this population. We're including rehab medicine, NDV, the therapy team, obviously neurosurgery, orthopedics, urology, and colorectal. We just heard such a wonderful presentation about dietary, social work, and neuropsychology. These kids are typically seen yearly or every 6 months, but really varies depending upon the needs of the child and what's going on at the moment. On the next slide, more specifically, the role of rehab medicine and physical therapy, at least during these annual visits to children's, we're looking closely at motor levels using the man muscle testing on the left to screen for tether cord, but also just to check in on how these kiddos are doing with respect to their strength, mobility, anticipated equipment needs, and anticipated level of independence, and how we can help promote that independence. Just really brief, physical therapy obviously has a lot of roles, children with spina bifida, starting from birth to 3, working on developmental skills, but throughout the lifespan, focusing on functional mobility training, promoting independence, promoting participation in the community, obviously strength, range of motion, working on helping acquire equipment and recommending equipment, and orthotics, just to name a few. Folks from the Shirley Ryan Ability Lab and Ann and Robert Lurie Children's Hospital of Chicago have developed a relatively new functional classification system for individuals with myelomeningocele. The point of this was to simplify the classification system based upon motor function as opposed to just the physical lesion level in the spine. And this will hopefully provide improved gait prognosis, patient care decision-making, and communication among health care providers and families. This system is integrating qualitative and quantitative information about the functionality level of patients using manual muscle testing, plus a scale called the functional mobility scale. These next 2 slides are what I've kind of used in the past to do something similar to this, just a little more clunky and detailed. This one is from the International dysplasia study group that I'm sure a lot of you have seen in the past. That's just another slide of showing how we rate manual muscle testing. And then a slide regarding, okay, if these muscle groups are working, then what is our anticipated functional mobility? What kind of equipment will we need? What kind of orthotics? So this new system is simply kind of clarifying and simplifying this, but also adding in this tool called the functional mobility scale that you've probably seen used also with children with cerebral palsy. The functional mobility scale that you can see on the screen rates the child or the person it looks at how they get from point A to point B over 3 different distances of 5 meters, which kind of represents household ambulation, 50 meters, which could represent school, and 500 meters, which represents more community ambulation or mobility, sorry. And then what you get is a number, a 1 through 6, based upon how you get from point A to point B at these different distances. For instance, a number 1, this individual is utilizing a wheelchair, a manual wheelchair. For a number 2, they're utilizing a 4-wheel walker. Number 3, crutches. 4, canes or sticks. And 5, they're pretty independent, but might need a railing on the stairs. And then number 6, independent with no external devices. So I'm not sure how well you can see that screen, but that gives you all the details. Okay, so this is how this all shakes out. Diaz and Swaroop did a lot of research with this, and this is kind of what they're finding. So they made 4 different classifications groups depending upon the manual muscle testing of the child. And what they're calling functional in these muscles is a grade 2 or better, which means partial anti-gravity movement up through being able to take full resistance. So you'll see how these shake out. And then what they've also done is looked at these individuals and said, okay, so kiddos that have this certain muscle function, what generally is their functional mobility scale score? And then based upon those 2 pieces of information, we can predict, or at least almost predict, what kinds of assistance this individual is going to need for their mobility. I'm going to sip of water. So this is a pretty pared down version that you're seeing right now, but I'm going to go into just a little bit of detail. And it's important to remember that not everyone fits into these exact classifications, and that's not what they're trying to say. They're just trying to help caregivers and care providers and medical professionals communicate realistically about what we can expect at different levels. So for folks falling into MMFC1, these kiddos are going to have the most significant muscle weakness. It's this level can typically be predicted at birth. These individuals will typically need an RGO, or that's a reciprocating gait orthosis, or hip, knee, ankle, foot orthosis, plus walker or crutches. The FMS, or the functional mobility scale, is typically a 2-1 under the age of 11 years, but can go down to a 1-1-1, meaning requiring a wheelchair between ages of 11 and 13 years of age, just because of increased in size, weight, and energy cost of ambulation for these kiddos. In the MMFC2, This one is predictable more by age 4. It's going to take a little while to predict this level. These kiddos need a walker and AFO prior to age 4, and maybe graduate to crutches and AFOs after age of 4, just because of the coordination and the learning involved with using crutches. FMS scores are typically 333, 332, or 331 before age 13, and then may go to a 321, 221, or 211, meaning they might utilize a manual wheelchair for longer distances. For MMFC3, this again is generally predicted by age 4 years. These individuals are typically independent with ambulation with just AFOs. They may benefit from crutches for longer distances, especially if there's a pretty significant gluteal lurch. These FMF scores are 555, 553, 533, and as adults may go to 551 or 531. And then finally, MMFC4. This, again, can be predicted as a newborn. These individuals may need like a supramalleolar ankle foot orthoses or insoles for proper foot alignment, but otherwise generally aren't requiring any orthotics or equipment, and their FMS score is going to be a 666. What I really recommend is to look up this reference article. It's really interesting and informative. This was a 1-hour webinar that's available on the Shirley Ryan Ability Lab Academy, mouthful. It's called The Orthopedic Care of Spina Bifida, and is super interesting, really informative regarding this new classification system, but also kind of highlights how they make orthopedic and surgical decisions using their gait lab and using the functional classification system. So I recommend checking that out. I tried to kind of take a look at what was new out in the literature. But some of these are, I think we looked at the last 10 years of literature. And some of the themes that kind of shook out were electrical stimulation, whole body vibration, early treadmill training, and then wheelchair skill training. So I'm going to start or move on with electrical stimulation. So I didn't find tons of research with kiddos with myelomeningocele. Most of the classic research is with children with cerebral palsy. And in those studies, findings suggest improvements in some of the GMFM, which is the gross motor function measure categories, including in sitting and standing. There is a woman, Gina Montevelli, who is a therapist who is doing a lot of electrical stimulation with kids with myelomeningocele. And I'm going to talk a little bit about a case study that she did. She did a case study with a 6-month-old boy, starting at 6 months of age anyway, with myelomeningocele. This kiddo's actual lesion was L2 to L5, but he also had a really interesting presentation with an underdeveloped upper thoracic spinal cord and a syrinx in his upper cervical spinal cord as well. He demonstrated no lower extremity muscle activity with a functional motor level of T10. Sensation was about T6 and above, and spotty below T8. So her intervention it spanned the age of 6 months to 18 months of age. Intervention included early intervention physical therapy 2 to 3 times per week in the clinic, plus home program exercises provided, plus functional electric stimulation to the glutes, quads, gastroc. Then after 6 weeks, they added back extensors. This took place 15 to 30 minutes twice per day, either in the clinic or the home. Then they added transcutaneous spinal cord stimulation to try to address this kiddo's trunk control. And they placed these, they did this over the spine at T12 to L2 and then added a C7 to T12. So the results, they found increased but spotty lower extremity sensation through the S2 dermatomes. They found increased circulation in the feet and lower extremities. Just as a context, this kiddo's feet and legs were pretty cold and pale initially, and then by 18 months of age were warm and pink, well perfused. They noted increased spontaneous intermittent lower extremity muscle contractions. However, these weren't volitional or functional. But most importantly, they noted improved trunk posture in sitting and assisted standing, which really helped with this kiddo's ability to be positioned and interact with his environment. So that is what she found. So now I'm going to move on to another section of literature that I explored, which was whole body vibration. I kind of knew what this was before, but I really didn't have a lot of experience with it. So it was really interesting learning about this. The theory about whole body vibration is you're standing or sitting or you're placed on a platform or plate that produces high frequency, low magnitude vibration. This is transmitted indirectly through the user's lower extremities. You can see some pictures, some examples. This is just one brand. I feel like we had it in service one time at Children's. They brought in one to show us, but they have varying degrees of supports around them. So a study by Imara looked at the effects of whole body vibration on bone mineral density. The purpose of this was to look at the effect of whole body vibration on bone mineral density in children with myelomeningocele. This researcher had a group of 20 children aged 2 to 5 years with lumbosacral myelomeningocele, and they were assigned to either a control group or a study group. So the control group received a special physical therapy program 3 times per week for 3 months. The study group received the same physical therapy program 3 times per week for 3 months. In addition to this, they also received 3 times per week whole body vibration. And the schedule for this was, they were 9-minute interventions, but they do 3 minutes on, 3 minutes off seated, then 3 minutes on, 3 minutes off kneeling, then 3 minutes off, 3 minutes on standing with their HKFOs and a support railing. So for the results, they measured bone mineral density at the proximal tibia, the neck of the femur, and in the spine. And they noted statistically significant increase in all these areas for both groups, but the effect was a little bit better in the study group for whole body vibration. So PT is really great for bone mineral density, and whole body vibration adds even a better effect. So hopefully they will do another study where they will kind of be able to parse out the difference between the PT effect and the whole body vibration effect. So this next group, Stark et al., these folks are out of University of Cologne in Germany. They were looking at the effects of whole body vibration in combination with a pretty intensive therapy program. They have a neuromuscular physiotherapy program at University of Cologne, and forgive my German, called Auf die Beine, or if you literally translate it, on the legs. This combined 6 months of home-based whole body vibration with 2 different blocks of intensive inpatient rehab stay. So initially there was a 13-day intensive inpatient stay And then after 3 months, another 6-day stay where these kiddos received 4 to 5 hours per day of physical therapy, pretty intense. In addition to this, they were receiving, in between, they were receiving whole body vibration, which I believe continued during their inpatient stay. So they took measurements at baseline, after 6 months, and then at a 6-month follow-up, so after 12 months. At the 6-month follow-up, they were using the GMFCS 66, or the Gross Motor Function Classification, or GMFM 66, Gross Motor Function Measure. And at 6 months, they noted significantly increased standing and walking scores, statistically significant increased walking velocity speed, and what they were describing as increased coordination and gait economy. They also noticed decrease in hip and knee flexion contracture during the active phase of the study. By the 12th month, they didn't note any additional significant changes. And interestingly enough, during the active phase of the study, they did note the decrease in hip and knee flexion contracture, but then at the follow-up, these kiddos had lost some of that range of motion that they had gained. So without that intensive therapy, they weren't able to maintain all those gains that they had, unfortunately. So then the next couple studies are a group out of Poland. And again, my pronunciation of names is not going to be great, but the first group, Zopa, maybe someone in the crowd is better with their Polish than me, was looking at the effects of whole body vibration on range of motion and blood flow. And part of this question came from the fact that previous studies by this group, and other groups, have shown that there was a significant correlation between hip and knee flexion contracture and altered blood flow, velocity, and resistivity in the lower extremity arteries in individuals with myelomeningocele. So the first study looked at the effectiveness of whole body vibration training incorporated into a conventional physical therapy program. So they assessed lower extremity range of motion and lower extremity blood flow. So the intervention looked like this. It was a 6-week program. So they received 2 weeks of PT only. Then they added whole body vibration in addition to the PT for 4 more weeks. So what they found was improved range of motion in the ankle, hip flexion, and hip extension with just PT. And then after adding whole body vibration, they demonstrated improved range of motion in all the joints, including knee extension. So the difference was that with adding the whole body vibration, we got at those knee flexion contractures a little bit better. With regards to the blood flow, there was no significant improvement after the 2 weeks of physical therapy, but after the 4 additional weeks of whole body vibration, they did show significantly improved blood flow. Okay. Can everyone still hear me?
Yes.
Good. Okay. All right. So the final study that I looked at for whole body vibration, they again looked at range of motion and blood flow, but with a different study design. This time, they divided 30 children with myelomeningocele between the ages of 7 and 16 into an experimental group and a control group. So one group received 3 weeks of whole body vibration, and the other received 3 weeks of physical therapy. Both groups showed significantly increased range of motion in all the lower extremity joints. Whole body vibration significantly improved lower extremity blood flow, meaning increased flow velocity and increased vascular resistance in the arteries, in addition to increased range of motion. And then there was no significant increase in blood flow in the PT group. So that we're looking at increased blood flow, increased knee extension, with the addition of whole body vibration, but the actual physical therapy is super valuable in increasing range of motion in these kiddos too. Okay, so you might have heard about early treadmill training with little kiddos with Down syndrome. This was a study looking at early treadmill training with infants with myelomeningocele. This was a feasibility study, so they were just looking at, how feasible is it to try to institute this treatment program with these kiddos and with these families. They had 8 infants with myelomeningocele that completed 12 months of training. 2 additional infants completed 6 months of training, but were not able to do all 12 months for whatever reason. Training consisted of home-based, parent-administered treadmill stepping practice. 10 minutes per day, 5 days per week, beginning within 6 months of birth. So what these researchers measured was motor milestones. They looked at the number of alternating treadmill steps. They measured spinal level reflexes, and they looked at body composition. And all of these improved after the 12 months of training. They noted improved, so with the motor milestones, they noted earlier, and this is compared with other kiddos with myelomeningocele they had looked at in past studies, or that had been seen in past studies, not necessarily by them, but these kiddos who underwent the treatment had earlier rolling, they sat alone sooner, they pulled to sit earlier, and they walked earlier. And one of the explanations they had was that the rhythmic coupled movement through repeated cycles of stretching the leg extensor muscle and swinging the leg forward during the treadmill stepping may have had something to do with increasing or improving the acquisition of these early motor milestones. With regard to alternating steps, they noticed increased alternating steps versus parallel steps. So if you can picture getting a full alternating step versus just stepping parallel with the other foot. They didn't increase the actual number of steps, just the quality of the alternating steps. Then with respect to spinal level reflexes, what they've seen in the past is that the peripheral 1A pathways are depressed across the first 10 months of life in infants with myelomeningocele. So they were looking at if there was any effect on that. And in the study, the reflex response frequency after the intervention was actually similar to age-matched peers without myelomeningocele after training. So in essence, the stepping training is helping to compensate for some of the sensory motor impairment that babies with myelomeningocele may have. And then with the body composition, I had to reread this part of the study multiple times to figure out what they were getting at here. But this is my explanation for this. We've heard about how the stepping response is thought to disappear when the infant, when the fat on the baby increases faster than muscle mass. So in the study, what they found was that as these babies got bigger and heavier, the stepping response did slow down, but it did not completely disappear with the ongoing practice. So that was the results from that study. So I found a couple studies about wheelchair skills training that I thought were just really great to look at because, in our neurodevelopmental clinic at Children's, we didn't do a lot of direct wheelchair skills training. So I'm thankful to the PTs in the community and school PTs and families who are getting this done. But these were some interesting studies that looked at developing training programs for families. The first one by Gowran, which took place in Ireland. This group developed, the purpose of this study was to develop and evaluate a wheelchair skills information pack for families, and also to investigate the impact of wheelchair skills training on children's performance of their wheelchair skills. And finally, they wanted to explore parents' perspectives on how training had influenced their children's daily participation. So they did pre and post test of the wheelchair skills test, which is a actual test that they used in another study that I read. And then they also used the software called Photo Voice to collect parent comments throughout the whole process. The study utilized 3 to 8-year-old children with spina bifida and or diagnosis of hydrocephalus. These kiddos received 1 hour of training, four 1-hour training sessions over the course of 5 weeks. And what they found was, lo and behold, practicing the wheelchair skills increased their performance and wheelchair skills. But it also highlighted gaps in the provision of services, of wheelchair provision services in Ireland, just really notable in the parent comments. So they got a lot of nice perspective with that study. The next study, we couldn't find the whole article, so I apologize. This is an abstract only. So if anyone knows how to find this actual article, I would love to read the whole thing. But it's kind of what do I want to say? It's an ongoing study. There was one based on adults, and now they've kind of altered this wheelchair skills training program for children. It's called Skills on Wheels, and the purpose of it is to build on wheelchair skills training, an already existing wheelchair skills training program, and now they're focusing on children. So what they did was they provided 5 weeks of training incorporating wheelchair skills that start with really lower level all the way up to higher level. This was 5 weeks. And what they found were improved scores on the wheelchair skills test. And almost more importantly, they noted gains in self-advocacy, gains in community participation, and decreased fears of falling. Very important. So that actually concludes the information part of my presentation. I hope that you were all able to take something useful away from this talk. Please feel free to reach out if there was a gap that you didn't quite get in the information. I really believe that the myelomeningocele functional classification system could be super effective in standardizing how care providers talk about functional levels and prognosis. And then regarding promising adjunctive therapies, I encourage all families and care providers to be really curious and open-minded, but also to think critically and do your research. Look for evidence provided by research that shows meaningful and functional benefits. Thank you again for listening.
Thank you so much, Solveig. I really, there's always innovations being done, and appreciate the review that you did of the new functional classification system. That's really cool and exciting that has, taken place. And thanks for reviewing some of these adjunctive therapies. There's always work being done to kind of improve care and quality of life for our patients and families. I agree with you, just being curious about some of these things, but also, approaching things with caution as well, since some of these, many of these adjunctive therapies don't have a ton of evidence base quite yet. And so work needs to be done, more research needs to be done for sure in future.
Absolutely.
Yeah. Thank you. Trying to see if there's anything in the chat for questions. There's a question from Dan Doherty. What are the proposed physiological mechanisms for the impact of WBV on range of motion and circulation? Whole body vibration. No problem if that wasn't highlighted in the papers.
Yeah, let me see. So what they're saying is that this, the vibration is causing repeated contractions of the muscle just through stimulation of the tendons and nerves, and that those repeated contractions are helping to increase range of motion and blood flow. I didn't really get a more scientific explanation than that, but that is a very good question, Dr. Doherty. Maybe someone in the audience has an answer to that. But I thought it was due to the repeated contraction that the vibration caused.
Dan said, cool.
There's a question from Amy. Amy says, thank you so much, Solveig, for synthesizing all this information. Wondering if you came across or have any experience with use of exoskeletons in spina bifida. This is a question that came up in my clinic.
Oh, that's a great topic. I have no personal experience with that. And that wasn't part of the literature that popped up when we did our review. So unfortunately, I can't speak to that right now. But again, maybe someone in the audience, I know UW was doing some work with that.
Amy, could you maybe unmute and tell us, explain to the audience what an exoskeleton is? When you said it and I read it, I was thinking about insects, which then I figured it out. But like, if you could tell us a little bit more about it and how it's come into your experience.
Great question. It's something that comes across more commonly in the spinal cord injury population. I know, like when I was a PM&R resident at Craig, which is a spinal cord injury center, they were using them. But it's kind of, it's helpful to Google it and look at a picture of it, honestly. But it's like basically like a brace that can help patients with paraplegia walk, and there's different types. I don't have a lot of experience prescribing them or using them, but I know it is something that's out there that I had a family ask me specifically about for their child and didn't have a great answer, so I'm polling the group.
I'm seeing some anecdotes in the chat around use of exoskeletons, mostly around, as you said, Amy, kids with spinal cord injury. And then I think there was Anna Fragamenti, one of our physical therapists at UW, said that the research was done in kids with cerebral palsy, if I read that correctly.
Thank you. There is a question from Leilani. What are some specific exercises you do with your patients?
Yeah, unfortunately, right now, I'm not working with this population. And at Children's, I was part of the Neurodevelopmental Clinic, where we did these biannual and annual evaluations, looking really in detail at range of motion, sensation, manual muscle testing, mobility. So I'm probably not the best person to ask for really exciting, novel exercises. Let's see. Did you have a specific age range in mind?
In the chat, we have ages 3 to 5.
3 to 5. Okay. So, I mean, not necessarily specific to spina bifida, but just really making things, playful and functional for that age. Yeah, just making it real play-based and functional and repeatable at home, so lots of practice can happen. And, these kids are getting ready they might be in developmental preschool, but getting ready to go to school full-time. So really looking at functional mobility and how are they going to get around their classroom and down the hallway, those types of things, but also just really touching base with the family and looking at what are the goals of the family, what's important to them at that moment, and then just trying to come up with activities that target those things.
There's a question in the chat from Celeste. What about the Trexo? I know children's outpatient therapies had one at one point. The Trexo is an overground assist gait trainer.
Yeah, and again, sorry, I actually didn't personally use that when I was at Children's, but pipe in. I know there's plenty of children's therapists on this that maybe have used it down on the 6th floor. Anna said it's moving back to Children's, so maybe you'd have had it for a little while.
I don't think I've ever even seen it, but it seems like it might be a really cool piece of technology.
Yeah, it is a cool piece of technology, and I think it probably would have a really important place in therapy with certain kiddos, just depending on their level of their motor function.
Hi, this is Anna Fragomeni. I was just going to say the study at UW with the Trexo was combined at times on and off with spinal stimulation also, which I know had been done, and that was in children with CP. It's a pilot study, and I know the results aren't out yet. And it's I believe, if I don't say this incorrectly, it's a study combined like folks from Children's and UW working on it together. I believe the Trexo's headed back to Children's if it's not already there. And I think it would be very wonderful to look into this for this population too.
Thank you so much, Solveig. I really, really appreciate your coming to talk to us today, and thank you.
Thank you, my pleasure.